Hello and welcome to the first of a special series of interviews recorded as part of Intellect's In Conversation podcast. These episodes focus on contemporary general practice, and the series is brought to you in collaboration with two practicing GPs, Doctors Rupal Shah and Jens Foell. Rupal and Jens are the authors of Intellect's highly anticipated Fighting for the Soul of General Practice, The Algorithm Will See You Now, a book which discusses themes affecting general practice, including industrialization versus craftsmanship, the effect of protocol, and the breakdown of relational care. Rupal Shah is a GP in inner city London and works as an Associate Dean for NHS England. As well as her many academic publications, she is a co-author of Our Mothers Ourselves, a memoir of mothering. Jens Foell is a practicing GP and academic who is deliberately choosing to work in undifferentiated primary care rather than a specialist service. He has an interest in mental health, chronic pain, and health policy, and was also trained in rehabilitation and social medicine. On today's episode, I'm joined by special guests, Doctors John Gillies, Carey Lunan, and Stewart Mercer. John Gillies, who was a rural doctor in Malawi and then a GP in rural Scotland for many years, has published on the philosophy of medicine, medical ethics, and the organisation of health services. He is an honorary professor of general practice at the University of Edinburgh. Carey Lunan has worked as an NHS GP for 20 years, mostly in areas of high socioeconomic deprivation. She is the chair of the Scottish Deep End Project and the past chair of the RCGP in Scotland. She is also a GP advisor to Scottish Government on health inequalities and mental health. Stewart Mercer is a general practitioner and professor of primary care and multimorbidity at the University of Edinburgh. Stewart has been a GP for almost 30 years. During this time, he's combined academic research and also his work as a general practitioner. His focus is often multimorbidity, with a particular focus on general practice in deprived areas of Scotland. The topic of this conversation is the soul or essence of general practice. And so to begin with, John, I would like to ask you about your 2009 co-authored paper, Distilling the Essence of General Practice, a Learning Journey in Progress. I think it'd be really useful, actually, if we could begin, perhaps if you could just summarize the findings of your paper.
Thank you, and thank you for your interest in the Essence of General Practice paper. It's available on the British Journal of General Practice website free. So this project arose in response to the 2004 contract, which established the Quality and Outcomes Framework and registered patients with the practice rather than VP, among many other things. And it was a project between RCGP Scotland, NHS Education Scotland, academics, including Stewart Mercer, patients, 40 GPs and registrars, and an independent think tank called the International Futures Forum. And we spoke to GPs, we spoke to patients, we went to other premises and practices and organizations. And we kind of tried to distill what was important in general practice. We also looked at changes in society at the time, things like economism, individualism, rise of the internet, then comparatively new, and the changes in general practice as well, more female GPs, what the GMC was doing. So we kind of distilled what the qualities that the general practice would need in the future, the key roles, and also the main advantages of general practice as the main primary care vehicle for patients in the future. The qualities we identified were things like a robust intellect, passion for knowledge, altruism, awareness of justice as an important societal force, respect for patients and empathy, and capacity for innovation, as well as team working. The key roles haven't changed, so I won't spend time on these since we're short of time, but probably the most important thing was that we tried to distill, if not a single sentence essence, the main advantages of general practice. And there were 6 of these that we identified. The first was trust achieved by high quality empathic communications and relationship-based care, essential for effective gatekeeping, and also a kind of rhetoric and an assumption of good intentions lie behind trust. Second was coordination in dealing with multiple problems and issues, coordinating social care, hospital care, voluntary agencies, and so on. The third was continuity, often generated by repeated short contracts and strengthening relationships over months and years, and challenged by many trends, including new working practice and general practice, multiple care providers, and so on. The fourth was flexibility to address problems in the way that patients wanted, not necessarily that the NHS demanded, and that kind of conflict came through. Coverage, GPs saw over 90% of their patients in 5 years, which leads to useful opportunities for hard-to-reach patients and one-off screening. And also, finally, probably very importantly, is leadership, the ability to identify what needs to change, how to change quickly, how to be responsive to a situation, and how to respond to both individuals, but the population of your area. So these were the kind of 6 main advantages that constituted what we thought was the essence of general practice at that time. And that was, of course, 15 years ago.
Thank you, John. I really appreciate the summary. I think it's a great place to start. And thinking of 15 years on from this landmark paper, I think you'll all agree that general practice has experienced a decade of austerity, a global pandemic, a cost of living crisis, worsening social and health inequalities, further increased divergence of the NHS across the UK, with fewer full-time GPs and an increasing focus on multidisciplinary team models when it comes to care. The emergence of two-tier systems of healthcare across the UK, of course, it's increasingly a digital world that we're all operating in, a significant shift in the balance of specialism to generalism across the workforce. I think this is kind of a fair summary that you'll probably all agree with. So from this point on, I'd like to take a deeper dive into some of these topics and what we mean really by the essence of general practice in this context. Here, can I just ask Stewart, what's your take on all of this?
So I think one of the key things that's changed at population level, and that's reflected in the patients we see, is the rise of an aging population. People are living to an older age, which is a great success, but that brings with it complications. And now having multiple long-term conditions within an individual patient, or so-called multimorbidity, is now the norm rather than the exception in most of the patients who consult GPs. A recent study I did, 8 out of 10 consultations in routine general practice were with multimorbid patients. Why is multimorbidity an issue? Well, because really it leads to complexity, both for the patients, the families, the clinicians, and society at large. And why would I say that? Well, we know from lots of research now around the world, multimorbidity reduces length of life, it reduces quality of life, and it leads to sometimes spiraling health and social care costs because of our tendency to have a fragmented and secondary care driven system, both in the UK but also in many other countries. So this isn't going to go away. The rise in multimorbidity is going to increase, and that demands exactly the skills that GPs have as expert generalists. Of course, we need specialists for episodes of care, but the mainstay of treatment for multimorbid patients needs to be generalism. And GPs are the only group of doctors who provide that across the life course. So that's why it's really a key part of the essence. We shouldn't think that multimorbidity is only about aging, because it's also to do with health inequalities. And we know that people in deprived areas in the UK, in the most deprived areas, develop multimorbidity 10 or 15 years younger than in the most affluent areas. So that has big implications for inequalities in health. And I'll stop there.
Thanks very much.
Your hand over.
Thanks, Stuart. I think this is a great time to bring in Carey. Carey, what's your perspective on this one?
Thanks, Stuart. I guess so, building on that last point there about early onset multimorbidity in our more deprived communities, what that essentially means is people living shorter lives in sicker health. And of course, in the last 20 years or so, and certainly since this paper has written, we've seen health inequalities widen across the UK, particularly in Scotland. We've seen life expectancy stall, and we've seen the gap in healthy life expectancy between the most and least deprived areas widen to more than 25 years. And we know that health inequalities are largely driven, of course, by the wider social determinants of health, but we also increasingly know and recognise that access to healthcare, and especially access to good general practice care, which is the universal first point of access to the NHS, is also a social determinant of health. And we know that access to healthcare is often poorest for those who need care the most, something described in 1971 as the inverse care law by Dr. Julian Tudor-Hart, who is a pioneering GP from Glencorrig in Wales. And he also observed that the inverse care law worsened when healthcare was exposed to market forces, which of course is very pertinent today as we see increasing emergence of two-tier systems of healthcare across the UK as people struggle to get their needs met within the NHS. And we know that this further worsens health inequalities. So it's probably interesting to think about what drives the inverse care law across the UK and how it manifests in our consulting rooms. We know that in the most deprived areas, we've got lower levels of workforce, we've got lower levels of funding when you weight it according to need. And that means that on the front line, we have less time to address the significant levels of unmet need of communities who are living these shorter lives in sicker health. And because the consultation rates are higher, because workforces are often smaller, the workload really can only be managed by offering shorter appointments. And when these are also infused with more social complexity, more early multimorbidity, not unsurprisingly, patients often report lower enablement scores and practitioner report higher levels of stress. So if we don't address the inverse care law, it's going to undermine our very unique potential and opportunity in general practice to make the most of our key attributes, our essence, if you like, to address health inequalities, our unrivaled population coverage, our ability to offer continuous care, which is especially important in more deprived areas, our ability to coordinate care and support navigation through our fiendishly complex systems, our ability to work within multi-professional teams, our ability to advocate on behalf of patients and to provide care in the context of their families and their communities in a holistic and a human and destigmatised way. And the Scottish Deep End Project, just to mention it, was established in 2009 to address the persisting inverse care law in general practice through bringing together for the first time frontline clinicians and academics from the 100 practices serving the most deprived communities in Scotland. And what that has done is it's created a community of practice, it's developed peer support networks, it's shared stories from the front line, and it's created an evidence base of what works well in these settings through workforce development, through education, through development of advocacy and involvement in research, and more recently in policy making as well. So we believe that general practice has a key role to play in addressing health inequalities if it's supported and enabled to do so, from the way that we recruit, train and support our teams, including ourselves, to be socially inclusive, trauma-informed, culturally competent, to the way that we design and deliver our services to be inclusive, including digitally inclusive and accessible and sticky, holding people in systems rather than discharging them from care, having a strong emphasis on relationship-based care and flexibility. And the golden thread running through much of this is having the time to do things differently.
Carey, thank you. I really appreciate those insights. That's a lot of food for thought there. Ru, I'd like to bring you in here as well. What's your take on all of this?
Yeah, thanks to Carey and to Stewart. Really, so important. In my opinion, I think the job of a GP is probably to combine evidence-based technical knowledge with other types of knowledge. By that, I mean perceiving the person in front of you, thinking about what matters to them, what their context is, how I can help them to adapt in the face of suffering and not be destroyed by it. I mean also thinking about the ethics of the situation, engaging with my patient and using my personal relationship and knowledge of my patient and their family to inform my decision-making process. And I think that's even more important for people whose stories are usually ignored by our official institutions and who are misrepresented so often. It's a book called The Crisis of Narration by a philosopher called Byung-Chul Han, who talks about the death of storytelling in GP surgeries. He says that doctors have neither the time nor the patience to listen. So he says, instead of telling my GP my ailments, today I'm encouraged to post symptoms on an app, which is designed to make medical care more efficient. But only certain forms of narration are permissible. So the app encourages patients to cram symptoms into tick boxes that specifically prevent them from giving a rich subjective account of how they're feeling. This is all paraphrasing Han. So he goes on to say, we're reduced to identikit puppets with identikit symptoms. And then he says, quality of care. It's a tale told by an idiot, signifying nothing. And the spirit of narration doesn't fit with the logic of efficiency. And I think this is a real challenge for us. If we're going to retain the soul of general practice, we need to recognize that healthcare is fundamentally a moral enterprise, and it's our duty to think about the effect that illness has on our patients, what it means to them, and what our own role is in their care. None of that can happen in the absence of relationships.
Thanks, Ruth. A point very well made. Jens, can I also ask you what are your takes on this question?
Yes, I'm a street-level bureaucrat as a GP, and I would say I'm doing a lot of listening. I love stories, but the problem is how they are represented in the information infrastructure and in how I do my work. Spike Milligan said there's a machine which does the work of 2 people. But unfortunately, it takes 3 people to operate this machine. And that's in a way the way I perceive technological advances, my contemporary working environment. What you don't see here is the 2 screens I have. I should have three screens soon because I have to handle so much information, emails, AccuRx, eConsult, shifted between each other, but they don't talk to each other. So I have to convert them, copy and paste, etc., etc. And that makes it very difficult because it grabs a lot of my attention. If you look, Julian Tudor Hart wrote the book New Kind of Doctor in 1988. The cover shows a female doctor. Yes, that's new. A telephone, paper notes, and no computer. Paper is patient. In German, you say Papier ist geduldig. You can draw on it. You can shift it between the patient and you. You can you can draw a genogram. You can represent the family. There's a lot you can do. And in the computerized version, it's more difficult to see the family, the environment. It's all individualized, and it's also funneled through protocols. So the computer is not an inert helper. The computer has authority. All the protocols are enshrined in the computer. The computer says no from Little Britain. Tuck, 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 computer says no. Every time I do a referral, computer says no. So it's very difficult to improvise, to be in the moment. And as a street-level bureaucrat, I have to reconcile the requirements of using technology with being in the moment, helping the patient, being holistic, seeing the family, seeing the wider network, which I do. But the job is bloody difficult, and the administration is really time-consuming. And everybody says, yes, the technology makes us more efficient. I wish that would be the case. The other bit is the informal way the guidelines and rules are constructed, and they breathe the paradigms of reductionism. So that creates a tension between me, the holistic GP, street level bureaucrat, and in the way I have to organize my work. I cannot just go down the corridor, speak to the district nurse and tell her how this person is, how the home looks like, and that I had a look at the fridge, etc. No, I have to do it in a complex way, and that slows the process down. It is what it is, but it makes relationships, generalism, very, very difficult. And that's actually what drives the system, what makes it useful, enjoyable, etc. So I am arguing for a system where technology actually serves the purpose, and that is something which we're struggling at the moment. General practice became highly technologized, far more than hospital systems. And on one hand, there's the promise that it speeds everything up. On the other hand, there's the revelation that it slows things down. So we are not yet in a position that we have reconciled the possibilities and the realities of working in a digitalized world. Last point I want to make is even in our training, we have not found yet ways of teaching that we are dealing in a mediated environment where the computer is part of the consultation, etc., which should not impede the magic of the interpersonal encounter. And if it is about access, there is, as Carey said, and Rupal, digital exclusion. The old adage says the poor, the old, and the sick will always be with us. They form 80% of our workload. But how do the poor, the old, and sick use technology? How can they organize? Everybody who is poor, old, and sick would need a secretary to organize their work, but they are the people who don't have a secretary and so forth. And as GPs, we are directly situated at this cusp between connecting all these requirements or operational dysfunctions and improvise, which is something we always did, and we are excellent in it. But as I said, it's bloody difficult.
Thank you, Jens. I thank you all as well. I really appreciate these valuable and concise insights on what is a rather complex matter. So thank you again. I really appreciate having all your opinions on this perspective. In conclusion, I'd like to ask each of you to keep it so. What is the one thing that must remain at the core or the essence of general practice? And to begin with, Stewart, what's your take on that?
So for me, I think the one thing that needs to remain the essence is holistic care, and holistic care for all patients. You know, we shouldn't just think, oh, it's only important for patients with complex multimorbidity. It is important for those, but it's important for all. So holistic care, and by that I mean the combination of high quality medical care and understanding that individual in the context of their mental health and in the context of the social circumstances. The biopsychosocial approach remains at the heart of the essence of general practice for me.
Thank you, Stewart. Carey, what about yourself?
This is a hard one, but I think for me, it goes back to one of the early points in the early paper from 2009 about an awareness of justice being one of the key attributes to being a GP. And I think I've been struck by, when I speak with young GPs, how many of them choose to go into general practice because they are interested in social justice and they're interested in activism and being able to bring about change. So I think it feels really important to harness that and cherish that and not lose it as we become a little bit disillusioned as we work through our careers. Because I think if we can find ways to become effective, practical advocates and use our voice on behalf of those who often have no voice, we can rediscover purpose and meaning in our jobs, which, as Jens says, can be bloody difficult. So that would be, for me, the main thing would be rediscovering and cherishing our role as advocates.
Thank you, Carey. John, can I bring you in here?
compassion is what I think is the most important thing in general practice. Compassion is quite simply an awareness and recognition of pain, distress, or suffering, and the taking of action to address that. And that has obvious relevance for our patients. I think also it has relevance for ourselves. And most people would say that we need, as busy professionals with dealing with a huge amount of complexity in our lives, as Jen has illustrated so well, we need to think of how we can be self-compassionate to ourselves, as well as being compassionate to our patients and to those around us in our teams. So both self-compassion and compassion to those around us are vital features of the general practice of the past, present, and future.
I think that's important food for thought there, John. Thank you very much for your contribution. Ru, what's the one thing that you would like to highlight?
It is a tough one, James, but I think it's meaning matters. We are so often on a treadmill and we don't really think about what we're doing. And I'd suggest that we need to do that, because if what we're doing isn't meaningful for our patients, for our colleagues, and for ourselves, we really need to pause and rethink.
Excellent, thank you. Jens, finally, can I just ask what your perspective is on this question?
As I said, my job is bloody difficult, but I'm good at it and I enjoy that. So I would say craftsmanship, because it's so complex. You have to do so much. You have to be a really good jazz musician, bringing people together, bringing dysfunctional chords together, making it work. And that's only possible through love. Yes, love, and I mean it. And connection, connecting to colleagues, connecting to patients, connecting to people who are hard to reach, and in a funny way that is possible and is really, really enjoyable. And it's difficult, but we are training a long time to develop these skills. That's fantastic. It's a very, very meaningful, giving way of being with people and creating change, belonging, being there.
Well, thank you all for your time and for these valuable insights. I think the soul of general practice is in good hands. I appreciate your time today. Thank you very much.